برضو يعني اشكر دكتور عماد شنودة على وجوده وتشريفه معنا النهارده في المؤتمر، واهلا بيه في بيته تاني طبعا. طبعا يعني as we are living in the era of immune therapy، فدكتور نورهان حسام هتقدم لنا very interesting presentation عن spectrum of radiological response to immune therapy in lung cancer. اتفضل.
Welcome and good afternoon. Our talk today is about the spectrum of radiological response to immune therapy in lung cancer. Our goals are about what is the indication of immune therapy in lung cancer, list different imaging findings of the lung cancer after immune therapy, identification of the atypical responses to immune therapy, early detection and identification of what is called immune-related adverse events. What are immune therapy? Immune therapy is a type of treatment that involves the immune system to fight cancer, targeting malignant cells. What are the indication and mechanism of action? The normal immune system identifies and eliminates precancerous and cancerous cells. However, tumor can develop immune resistance mechanism, one of which involves a pathway termed immune checkpoints that normally suppress the T cell function. Immune therapies or immune checkpoint inhibitors work by increasing the immune response to the target cancer cell to mount a more effective attack on cancer cells. Checkpoint inhibitors are active immune therapies as they interact with the host immune system to stimulate cell-mediated immune response. They also modulate the T cell activity by interacting with a specific cell surface receptor or ligand, which are critical in the cell-mediated adaptive immunity. Immune therapies can also cause a typical response pattern, such as pseudoprogression, in which the tumor burden shows initial increase but then decrease. Therefore, response criteria have been developed specifically for patients receiving immune therapy. Because immune therapy activates also the immune system, they can lead to inflammatory side effects termed immune-related adverse events. The immune checkpoint receptor, called BD1, is found on the T cell surface. The function of BD1 is to limit the T cell activation at time of inflammatory response and to limit autoimmunity. Some tumor cells work as some non-cancerous cells, human cells. They are expressing a ligand called BDL1 to allow it to escape the immune system. When BD1 present on the T cell surface, engaged by its ligand, T cell inhibition will happen, and immune therapy work to inhibit this pathway, leading to T cell activation, especially in the setting of non-small cell lung cancer and other tumor expressing BDL1. Immune therapy usually indicated in advanced or recurrent or metastatic non-small cell lung cancer, where the tumor cell modulates their BDL1 and escape the body immune system. This diagram illustrates how engagement between the BD1 receptor present on the T cell surface with its BDL1 ligand present on some tumor cells result in T cell inactivation and allow tumor cell to evade or escape the immune response. Also, T cell activation inducing a memory cell response, which includes memory T cells that may provide long-term immune protection. In advanced lung cancer, patients were demonstrated that combination strategy based on immune therapy plus chemo or radiotherapy significantly improve free survival rates and improve therapeutic efficacy. The use of imaging to evaluate immune therapy response. The gold standard test is PET-CT or CT chest, and we use what's called iRECIST criteria specific for patients receiving immune therapy, the immune-related response evaluation criteria in solid tumor. All radiological findings may function as a non-invasive biomarker predicting immune therapy response. What are the classic response and according to iRECIST criteria? The classic response could be categorized as 4 groups using iRECIST criteria: complete response, partial response, stable disease, and progressive disease. And progressive disease is further classified into immune unconfirmed progressive and immune confirmed progressive. Complete response means complete resolution of all lesion, and this is confirmed after 4 weeks. Partial response, decrease in the tumor size by more than 30% from the baseline in absence of new lesion or any progression. Stable disease means neither response nor progression. What about progressive? Progressive disease is further classified into immune unconfirmed progressive disease when the tumor increased by more than 20% or appearance of new lesion, and this state of unconfirmed progressive need to be confirmed after 4 to 8 weeks. To state immune confirmed progressive disease, there is more increase in the tumor size or appearance of new lesion, or even increase in size of the new lesion after the state of immune unconfirmed progressive by 4 to 8 weeks. This is an example of complete response following immune therapy in 41-year-old female diagnosed with stage 4 poorly differentiated lung adenocarcinoma. In right upper loop, we can see the mass hypodense, the adenocarcinoma in the right upper loop with a hypodense subcutaneous lesion and pancreatic metastasis visible in the baseline CT in image A, B, C. A shows a primary lesion, B shows a subcutaneous lesion, C shows a pancreatic metastasis. A complete response was obtained 12 weeks after therapy at the primary tumor and the subcutaneous lesion, and only a secular calcification could be seen at the site of pancreatic lesion. And this is an example of complete response to immune therapy. Example for confirmed progressive disease in a 64-year-old male with right hilar adenocarcinoma. Baseline contrast enhanced CT show right hilar mass. 2 months follow-up show stable disease, no regression or progression. However, at 4 months follow-up, the right hilar mass further increased in size with development of enlarged axillary lymph node looking suspicious, and this state, according to IRISIST criteria, we call it immune unconfirmed progressive disease and must be followed up again at 6 months follow-up. There is a state of confirmed progressive disease was established due to continued growth of the target lesion or right hilar mass and the axillary lymph node. What are the atypical response to immune therapy? An initial increase in tumor size followed by decrease is called pseudo-progression, or development of new lesion after start of therapy that shows stable course or disappear during continuation of treatment. Marked growth of the target tumor or its metastasis faster than expected is called hyperprogression. Development of immune-related adverse event in patient treated with immune therapy. This is considered a typical response to immune therapy, and they will discuss later. The phenomena of initial increase in tumor size and or appearance of new lesion followed by decrease in tumor burden has been described as pseudo-progression. What are the causes of this increase? Infiltration of immune cells that target cancer cells are believed to be responsible for the increase in the tumor volume as an inflammatory reaction rather than tumor cell proliferation, which usually seen in the first 3 months after initiation of therapy. However, pseudo-progression is a relatively uncommon phenomena with an incidence of only 0.6 to 9% of non-small cell lung cancer patients, and patient experienced pseudo-progression had longer overall survival compared with the standard progressive disease. Example of pseudo-progression in a 60-year-old woman with non-small cell lung cancer. Image A show axial CT before therapy, show a mass 2.7 centimeter at the left upper loop. Image B, CT image 6 weeks after the start of therapy, show enlargement of the tumor to 4.5 centimeter, which raised the suspicion of disease progression, and according to IRISIST, we called it immune unconfirmed progressive and must be confirmed. On image C, image 14 weeks after the start of therapy, show a decrease in the tumor size to 1.5 and establish a diagnosis of pseudo-progression, which refer to initial increase in tumor burden followed by decrease in tumor burden. Another example of pseudo-progression by another criteria, pseudo-progression in 65-year-old patient with lung carcinoma treated with immune therapy. Baseline CT show lung mass in the upper right loop with normal adrenal gland. Yet, at 38-week follow-up, there was a good reduction in size of the lung mass, which is a target lesion, but a new lesion was appeared in the right adrenal gland, the white arrow. The patient was maintained under the same treatment, and further follow-up at 44 weeks, the right adrenal mass disappeared, completely confirming the diagnosis of pseudoprogression. Another example of atypical lung response is hyperprogression. It is a dramatic increase in tumor size in patients who started immune therapy and usually with poor prognosis. The progression is usually faster than expected to that cancer. Hyperprogression was described in about 13.8% of patients treated with immune therapy. Example of hyperprogression in 73-year-old male patient with non-small cell lung cancer. Row A show baseline CT, the primary lung mass, a black arrow in the second image, row B, row A, and bilateral adrenal metastasis. Row B, 8 weeks after starting of immune therapy, show newly developed multiple soft tissue and axillary suspicious lesion, metastatic lesions, and marked progression regarding the size of the primary lung lesion and bilateral adrenal glands. This progression is faster than expected to that tumor, and this is called hyperprogression. What are the immune-related adverse events? A spectrum of adverse events that occur due to stimulation of the immune system, especially T cell, causing inflammatory or autoimmune reactions, can affect any organ from the skin and digestive tract to the liver, endocrinal gland, or lungs. Radiologists must be able to distinguish these immune-related adverse events from recurrent or metastatic process. Some adverse events, such as skin rash, are obvious on physical examination, but others, such as sarcoid reaction, fasciitis, or fat stranding, may be silent and manifested only on radiological studies. Before they are clinically evident, for early detection and management, the management is very easy, either by adding corticosteroid or temporary withdrawal of the immune therapy according to the severity. There are a wide spectrum of immune-related adverse events, but the most common two adverse events during treatment of lung cancer patients by immune therapy are pneumonitis and sarcoid reaction. Pneumonitis is a life-threatening adverse event, and it is more common with PD-1 inhibitor, for which incidence of up to 6% are reported. Pneumonitis occurred more frequently in patients with lung cancer. In patients with lung cancer, pneumonitis can be clinically and radiologically stimulate tumor progression or lung infection. Sarcoid reaction, this is a rare complication, but important systemic complication that can mimic progressive disease in lung cancer receiving immune therapy. Radiologically, it is characterized by appearance of lymphadenopathies and some perilymphatic pulmonary nodule, so it can be confused with progressive disease or lymphangitis carcinomatosis. Example for immune-related pneumonitis, CT image 8 weeks after initiation of therapy in a 56-year-old man with worsening dyspnea show diffuse ground glass opacity in the right lung. Other causes of ground glass opacity, such as infection, were excluded clinically and with bronchoalveolar lavage. And a diagnosis of pneumonitis was made. Symptoms improved after temporary withholding immune therapy and initiating steroid therapy. Another example of immune-related pneumonitis in a 76-year-old woman with non-small cell lung cancer show bilateral opacities, including right lower lobe, with a reversed halo sign, suggestive of organizing pneumonia. Infection also was excluded, and symptom improved after discontinuation of therapy. Although immune therapy-related pneumonitis can manifest with a wide spectrum of radiological finding, but ground glass opacities and organizing pneumonia are the most common manifestation. Sarcoid-like reaction means development of multiple lymphadenopathies and perilymphatic nodule. This is an example of enlarged mediastinal and hilar lymph node in patients treated with immune therapy. 12-week follow-up, PET CT image show typical hypermetabolic, symmetric mediastinal and hilar lymph node enlargement, and very suggestive of sarcoid reaction. These features disappeared on the following PET CT after 18-week follow-up. That confirms the diagnosis of sarcoid-like reaction under immune therapy. Patients with sarcoid reaction present a good overall state with signs of tumor response in other organs and respond quickly to corticosteroid. Another example of sarcoid-like reaction in 76-year-old patient with non-small cell lung cancer who received immune checkpoint inhibitor. Initial CT show metabolically active metastasis in the middle loop and right pleural effusion, the red arrow in the first image baseline CT. 4 weeks after treatment initiation, development of multiple intrapulmonary micronodule in a perilymphatic distribution were detectable in both lung, predominant in the right. In addition, there is enlarged metabolically active hilar and mediastinal lymph node were visible. This is consistent with sarcoid-like reaction, and the disappearance of the target lesion in the baseline CT suggestive of treatment response. To take a home message, the goal of immune therapy is to boost T-cell mediated immunity to mount more effective attack on cancer cell. Immune therapy have changed the treatment landscape of advanced non-small cell lung cancer. Response to immune therapy have been described to be more delayed, 4 weeks average, with slower decrease in the total tumor burden, but with durable response even after stopping the treatment by the activation of memory T cell. Special attention must be paid to the assessment of treatment response to immune therapy, as well as to the early detection and management of treatment-related adverse events. Immune therapy can cause atypical response pattern, such as pseudo-progression, so any initial increase in the tumor burden, not only indication of progressive disease and need confirmation more than 4 weeks to be confirmed progressive or established pseudo-progressive state. Therefore, IRECIST criteria have been developed specifically for patients receiving immune therapy. It is important to be aware that of the imaging appearance of the various immune-related adverse events to avoid misinterpreting them as metastatic disease or progressive disease or infection. Immune-related adverse events range from asymptomatic abnormal laboratory result to life-threatening conditions such as encephalitis, pneumonitis, myocarditis, hepatitis, and colitis, which could be managed by corticosteroid or temporary cessation of immune therapy treatment. Thank you.